So we have 10 minutes for discussion. We start by taking questions from the audience. Anyone has a question? Dr. Islam.
It's not a question. So can I have a mic, please? It is not a question. It is some note. I have my training, most of it about mix. So when I have the training, we mostly face with angry eyes because of the drops and the topical treatment. But the idea in the surgery or the time of the surgery, it is not just about inflammation. It's just also about how much blood it will be. So we were using iobidine drops. It's drops from Alcon. It's abraclonidine. It's some sort of alpha agonist. So it's blanching all the vessels. So it will come like clear. So it will be maybe clear area to do and to start. And my question for Dr. Basil, he speak about preserved flow stenting. You mean you're closing?
No. It's inserting thin zero nylon inside the lumen of the tube. Keep it in the total length of the tube, 8 millimeter. The total length is 8.5. Keep it for 8 millimeter, and do a loop on the limbus. Keep it for 2 weeks and pull it out after 2 weeks from the limbus.
So the idea is to preserve the pressure and to keep it still some high to keep the AC not to have collapse.
Exactly.
Okay, but you keep visco after the surgery, or you remove the visco from anterior chamber?
I'm not using visco at all in the anterior chamber with preserved flow. Trying to avoid, but it's mentioned in many by many surgeons to keep some visco on the tip of the preserved flow inside the anterior chamber when you are worried about hypotony or anterior chamber collapse, to keep visco as tamponade or to prevent.
This is what we have.
Yeah.
Even in the Express and even in the Xen. Even if it is combined or just only like mono surgery, we keep a little bit. We noticed that it may take like tamponade for maybe 24 hours or 36 hours just, and to keep it and prevent the hypotension.
Indeed, it's mostly advised for vitrectomized eyes.
Thank you.
Thanks, Dr.
About the preserved flow. First, should we consider it as a mix, minimal invasive?
No, it's not a mix.
Yeah, and
It's
if
MIPS.
it is, yeah,
It's another category.
Yeah.
Minimum invasive blip-related surgery.
yeah. And if not, so what's the advantages that preserved flow added more for the trabeculectomy?
This is what we are talking about. The complications less with preserved flow, mainly hypotony, anterior chamber collapse or shallowing, and the blip is posteriorly extended away from the limbus. So the blip-related complications post-op are less with the preserved flow, mostly, on the most of the cases, especially if you follow the guides that mean to apply mitomycin posteriorly away from the limbus, to cover the tube with the tenon first, then to suture the conjunctiva, and to use the steroids for long time, sometimes for 1 year at least, but we taper it gradually.
Okay. And Dr. Munir, you mentioned that you never used toric lens for the glaucoma if high cataract, multifocal, but maybe toric we can add it. If not mix.
Yeah,
Not
toric
big.
is not a big issue.
Yeah.
Obviously, especially if the patient has no keratoconus or so, yeah, definitely. But I'm talking about multifocal because there are two mechanisms for the glare and the reduced contrast in glaucoma. The optic neuropathy, especially if this is slightly advanced, it can reduce the contrast and the sensitivity of the
OCT,
colors.
You mean
No, I'm talking about the actual, what the patient can see.
clinically.
So you put multifocal, which will increase it, decrease it even more. So then they will be struggling. And the other thing is, all patients who are on glaucoma drops, they always naturally have dry eye. And they will have this kind of reduced contrast and color sensitivity and glare. So you are going to make it worse. So for me, and that's my personal approach, I don't offer multifocal for anyone moderate to, obviously above moderate glaucoma, I don't, or young patient, again with the glaucoma, because of the same reason, because I'm going to operate on them in the future, and even operation, it will create more astigmatism, change the shape of the eye, especially if this is myopic patient, then I will end up with more problem with multifocal.
Yeah, but do you think toric it's okay?
I think toric is okay unless if they have irregular astigmatism or keratoconus, but the actual toric should be fine, yes.
Yeah. Okay.
One more thing to mention, if you are operating on a young patient, the astigmatism will completely change as well. So they will need to be informed that they will need to have glasses again all the time, but it's not contraindication as such.
How about ADOF IOLs? I'd like to know the thoughts of the panelists on anyone has experience with implanting ADOF in mild, moderate, advanced glaucoma patients?
Enhanced monovision, you mean? Yeah. The enhanced monovision. Yeah.
Sort of.
Yeah. I think it's okay.
Yeah, so I think that there are a few studies out now that look at EDOFs in the mild group. And I think the mean deviation ranges from -4 to -8. It's really quite mild. And the results have been good. Not all EDOFs are the same. I think that's a thing we should say. In Singapore, we have the Vivity and the Pure C. And we'll probably find that the Vivity has a better reading ad and the Pure C has a less effect on contrast sensitivity. So we will prefer those in the glaucoma patients. Of course, you've got to be careful when you're... we have the luxury now of having lots of MIGs for these patients, which don't cause the astigmatism that the TRAB does. So there's some economies and efficiencies to be made with our current state of affairs.
No, actually, we have now a way through the eye trace to measure the contrast for the patients. For in early cases, we have like the MTF, the modulation transfer, and we can have the number of that. In low values of the MTF, so we have already low contrast, and those patients are not advised to go for even EDOF. In a patient with a mild glaucoma and high MTF numbers, we can go definitely for EDOF. The point is we need to just to avoid the ray splitting IOLs, because this is definitely not advised for glaucoma. Otherwise, we have now different modalities. We have changing in the posterior curvature. We have the transfer array. We have the stretch and shift design, different IOLs. So all works for glaucoma in a mild case.
And I think a pupil reaction should be taken consideration for any patient for premium lenses, either ADOF or toric lenses also.
Yeah, exactly.
In my case, I have experience with the VVT lens, for example, but always with mild to moderate glaucoma combined with mix. But I don't used to do it with TRAB or with tubes. If you see the patient is very symptomatic and you explain very well what the risk are about refractive surprise afterwards, and patient is happy, okay, we can try. We can give it a try. But if the patient has to pay the lens, if the result is not very predictable, I try to avoid it with filtering glaucoma surgeries. But with mix, with excimer laser trabeculostomy, with Glaukos, eye stent, I didn't have any surprise.
I just have one comment regarding the toric lenses. If your patient has had a trabeculectomy and it's been over 6 months, then probably you can put in. But in case you do a toric lens implantation and eventually the patient needs a trabeculectomy, the TRAB-induced astigmatism is going to alter the, the post-operative outcome. So it's better if you have to use a toric, at least use after a TRAB or whatever procedure you plan to do, so that the astigmatism is stable at least.
Okay, so one last question. When it comes to uveitic glaucoma, I'd like to know your thoughts or your prime go-to procedure in these cases, TRABs, tubes, or otherwise. Dr. Para?
I still like to do a trap first. I'm pretty old school on that. So a trap first, and if it survives with a good steroid cover, then usually I don't really end up needing a tube. Else later plan a cataract surgery and put a tube in the sulcus.
Well, I have a different point of view. In these cases, unless the inflammation is very well controlled, I wouldn't go for a trap. I will go more for a tube. But here in these cases, for example, PreserFlow could be a good option. Not a thick tube, no. But in uveitic cases, I think we can control the inflammation better. We don't have issues with the radiectomy. I feel more comfortable with this. And I was just going to comment something about PreserFlow as well, because Dr. started talking about the use of PreserFlow in the pediatric population. And recently, I was talking to people from one of the hospitals of reference in my country, where most of the cases of pediatric glaucoma are sent there, and they are moving to PreserFlow for a lot of cases. And myself, I have a very good experience with this in a pediatric case, when we have to save space in the conjunctiva for this young population. We think that they will need further surgeries in the future. I think could be a good option. No, sometimes we keep it for adults, but we need to think about the surgeries that we will do in the future. And I think that's one of the advantages of PreserFlow.
Yeah, I still agree with you. Actually, we can call now the PreserFlow as a trabeculectomy killer, simply. We are moving more and more in PreserFlow on almost most of the indications of trabeculectomy. Maybe only the angle-closure glaucoma. Still, we have some troubles in PreserFlow, as long as we are not able to open the angle. Fortunately and surprisingly, we have definitely outstanding outcomes in uveitic glaucoma in PreserFlow. Because anyway, in uveitic glaucoma, we're using steroids, and a steroid is necessary to keep the PreserFlow working. Those patients has no problem in just keeping on using steroid for a long time, as long as the patient even is like Sudafed or so. So outcome drinking PreserFlow is doing very well. Still using like larger tubes like the Pole valve and Ahmed valve in different situations like neovascular glaucoma mainly. For that, I prefer something like a big tube. Bulvert now we're still using, that's very, very declining because of the risks. And yes, Pole is definitely getting ground for that.
You mean in uveitic glaucoma?
In uveitic glaucoma.
Yeah. As Parol, I prefer to begin always with trabeculectomy if there is controlling for the inflammatory situation, though I go for trabeculectomy first, then maybe I can put a tube. I always prefer not to begin with a tube shunt. Yeah.
So inflammatory glaucoma, my preferred option, as Dr. Bassett said, is PreserFlow all the time. And I always tend, because they always tend to have hypotony post because of the ciliary body shutdown and everything. If this is not working, I give it one more chance and I do a revision. I don't do needling for PreserFlow. I always put it superior nasal and allow space for tube or trap. If this is going to still fail after the first revision, I do either trap or tube superior temporal. And I don't find like the success rate of trap, even with the PreserFlow, if you put it superior nasal, still excellent. It doesn't really affect the success rate.
Dr. Bassett Shamera, if you have to do a tube at either the primary procedure or after failure of trap, what's your preferred choice? Would you go for a Pole or an Ahmed? Or a Barville?
Indeed, Polynew here. I used it for a few cases. It's doing well with me. Indeed, I liked it. And encouraging to use it more. But previously, Ahmed Valve was the first choice. And we have a good experience with it since 25 years.
I think the simple advice is just go with what you know and what you're good at doing, get repeatable and good results with. That could be either of the two. I think over the longer term, the Pole will probably get you better pressures, but of course takes longer to do and may have more complications because it's the way it is. I think Pole has largely replaced the Barvelt, so I think that in most people's cases they will go for the Pole. But Ahmed, again, does work very, very well. It's valved, you don't get hypotony, etc.
Right. Thank you very much, everyone. That would end our session. I'd like to thank the speakers and panelists for the great talks, and we'll see you in a little bit for the glaucoma session too. Thank you.